welcome to the deep dive. Today, we're really getting into the weeds of something super important for any clinician.
Yeah,
The forearm, wrist, and hand.
absolutely. It's complex, no doubt.
Right, and this deep dive is specifically for you, our first-year med student listeners. We want to give you more than just facts we want to give you, like a clinical compass.
Exactly. Think of it as mastering the region, not just learning it. We're aiming for clear structure, those memorable anchors, practical stuff you'll actually use.
So what's the mission today?
Well, we're navigating the bones, muscles, nerves, vessels, all the intricate bits, but always with an eye on clinical relevance. Common injuries, what goes wrong.
Okay.
Mastering this, it's like having that compass for future diagnoses. You'll get the hang of clinical anatomy, why distal radius fractures matter, how to predict nerve issues, what those retinaculars do.
And carpal tunnel, right. Big one.
Huge one. And how infections spread, that too.
Okay, so here's the roadmap. We'll hit bones and joints first, then fractures relevant to that, then muscles, neurovasculature, and finish up with carpal tunnel.
Sound good. Sounds perfect. And just quickly on terminology, you're going to hear a lot of Latin. Don't let it throw you.
Right, Kirby.
Wrist. Digitorum fingers. Pollis is thumb. Longus is long. Brevis short.
Superficialis.
Yeah.
Superficial.
You got it. And profundus is deep. Interosseous means between bones. Knowing these just makes communication so much clearer. It's the language of anatomy.
Got it. The alphabet before the story, like you said. Okay, let's build that foundation. Forearm bones.
Yeah.
Radius and ulna.
The big two.
And you can actually feel parts of them, which helps make it real, like the radial tuberosity.
Where your biceps brachii attaches, you can feel that bump on the thumb side if you trace up.
And down near the wrist, in that little dip at the base of the thumb,
Yeah.
the anatomical snuff box,
Yeah.
you feel the radial styloid.
Yep, prominent pointy bit there. And on the other side, the pinky side, you can feel the ulnar styloid.
And of course, the olecranon, the point of your elbow, covered by that bursa. Feeling these landmarks really helps anchor the anatomy.
It does. And connecting those two bones, the radius and ulna, is the interosseous membrane. It's more than just connective tissue.
How so?
Well, it holds them together, obviously, but it's also a major muscle attachment site. And crucially, it transfers force.
Force transfer from radius to ulna.
Exactly. Most force hits the radius at the wrist, and this membrane shifts some of that load over to the ulna. It even has holes for blood vessels to pass through.
Fascinating.
So think about it. It holds bones together firmly, but it needs to allow some movement, some give, for things like pronation and supination. What kind of joint classification does that suggest?
Good question. Strong, but slightly flexible.
Hold that thought. We'll circle back to it later. It's a good one to puzzle over.
Okay, will do. And speaking of them being connected, here's a clinical pearl I learned. Think of the radius and ulna like a ring.
A rigid ring.
Right. And if you break a ring...
It usually breaks in two places.
Exactly. So if you see a fracture in one bone, you have to look for injury in the other. Could be another fracture, could be a dislocation. They're partners in crime, so to speak.
That's a perfect analogy. And that partnership is key for pronation and supination, turning your palm up and down. Those movements happen at the radial joints, proximal and distal.
And supination is the stronger movement, right? Turning the palm up.
It is, yeah. Powered mainly by biceps and the supinator muscle. Now, down at the wrist, the distal end, it's mostly the radius articulating with the carpals.
Which ones?
Specifically the scaphoid and lunate. The ulna is kind of kept separate from the main wrist joint by a little fiber cartilage disc.
So the wrist joint itself, what type is it?
It's a condyloid synovial joint, allows movement in two planes, flexion, extension, and adduction, abduction. And you can combine those for circumduction.
And it's held together by strong ligaments on the sides.
Yep. Strong collateral ligaments, radial collateral from the radial styloid to the scaphoid, and ulnar collateral from the ulnar styloid to the trichotrum. Keeps it stable.
Okay, solid foundation. Now let's connect this directly to those fractures you mentioned. The distal radius ones in adults seem really common.
Oh, you'll see them all the time. Two classic patterns. Get the visual and you'll remember them. First, the Colles fracture.
That's the Fouche one, right? Fallen outstretched hand.
That's the one. The distal fragment of the radius gets pushed backwards, dorsally, creates this characteristic dinner fork deformity.
Dinner fork. Okay, I can picture that.
Very common, especially in older women. Postmenopausal osteoporosis is a factor. And watch out for median nerve damage with these.
Good tip. And the other one?
The Smith's fracture. Less common. Here, the distal fragment goes the other way, palmarly or anteriorly, gives it a garden spade deformity look.
Garden spade.
Okay.
Colles is dinner fork, Smith is garden spade. Got it.
Those images help, Now, kids are different. Their bones heal fast, which is good.
But you have to think about other things too, right? Like non-accidental injuries sometimes.
Sadly, yes, that's always a consideration. And critically, their growth plates, the epiphyses, fractures involving the growth plate Salter-Harris classification are a big deal because they can mess with future growth.
And they get those incomplete fractures too.
Right, because their bones are softer, more flexible. Like bending a green twig, you get a green stick fracture where one side breaks but the outer layer, the periosteum, stays intact. Or sometimes it just buckles under pressure, a buckle fracture.
Okay, different patterns to watch for in kids. Now, moving into the wrist proper, the carpal bones.
The 8 little pebble-like bones, 2 rows, memorizing them is key.
Is there an easy way?
There's a good mnemonic. Start on the thumb side, laterally, proximal row first. Straight line thumb to pinky.
Straight line thumb to pinky.
Okay. Scaphoid, lunate, trichotrum, pisiform. That's the proximal row.
SLTP.
Got it. Then the distal row, again starting laterally. Here comes the thumb.
Here comes the thumb.
Hemat, capitate, trapezoid, trapezium.
HCTT. Okay, straight line thumb to pinky. Here comes the thumb. Scaphoid, lunate, trichotrum, pisiform, hemate, capitate, trapezoid, trapezium.
Perfect. And these bones form that arch, which, with the flexor retinaculum ligament over the top, creates the carpal tunnel.
And you mentioned the scaphoid is particularly important clinically.
Very. That fall on the hand we talked about.
Yeah.
If the patient has tenderness right in that anatomical snuff box,
Suspect a scaphoid fracture.
by suspicion. And here's the critical part. It's blood supply. It's kind of precarious.
How so?
It mostly runs distal to proximal, meaning the blood vessels enter at the far end and run back towards the wrist.
So if you fracture it, especially near the middle or the proximal end,
You can cut off the blood supply to that proximal fragment, which can lead to
avascular necrosis.
AVN.
Exactly. The bone tissue dies. It's a major complication you absolutely need to be aware of. Such a small detail, huge consequences.
Wow. Okay. Any other key fractures in this area? Quickly, Bennett's fracture is one to know base of the first metacarpal, the thumb metacarpal, and fifth metacarpal fractures, often from punching something, the boxer's fracture.
Got it. So much clinical relevance packed into these bones.
Yeah.
Okay, let's switch gears to the muscles, the movers and shakers, starting with the anterior forearm, the flexors.
Right, the flexor compartment. And the key organizing principle here is their origin. Almost all of them arise from a common point.
The medial epicondyle on the humerus.
Precisely. The common flexor origin. So pain right there, you're thinking medial epicondylitis.
Golfer's elbow.
That's the one. Now, innervation. Here's your first golden rule for the forearm. It simplifies things a lot.
Okay, I'm ready.
Everything in the anterior forearm is supplied by the median nerve,
Everything.
except for 2 exceptions. The flexor carpi ulnaris muscle and the medial half of flexor digitorum profundus, the part that goes to your ring and little finger.
Okay, so median nerve mostly, but FCU and medial FDP get the ulnar nerve.
You've got it. That's the rule. So let's glance at the layers. Layer 1, the most superficial, has 4 muscles: pronator teres,
Pronates the forearm, median nerve.
flexor carpi radialis,
Flexes and abducts the wrist, median nerve.
flexor carpi ulnaris.
Flexes and abducts the wrist, ulnar nerve, our first exception.
Right. And palmaris longus. Wrist flexor, median nerve, but it's absent in maybe 20% of people.
Interesting. Okay, layer 2.
Just one main muscle there. Flexor digitorum superficialis, FDS, flexes your fingers at the middle joint, the PIP joint, median nerve.
And layer 3, the deepest.
3 muscles here. Flexor pollicis longus flexes your thumb's end joint, the DIP, median nerve, then flexor digitorum profundus, FDP.
The other exception is in here somewhere.
Yep. FDP is the only muscle that flexes the very end joints of your fingers, the DIPs, and its innervation is split. Lateral half, digits 2 and 3, gets the median nerve. Medial half, digits 4 and 5, gets the ulnar nerve.
Okay, so testing DIP flexion in the little finger tests, FDP and the ulnar nerve.
Exactly. And the last deep muscle is pronator quadratus, helps pronate the forearm, median nerve.
That golden rule is super helpful.
Yeah.
Okay, let's flip over to the posterior forearm, the extensors.
Right. And just like the flexors had a common origin.
Extensors have one too, lateral epicondyle.
You got it. Common extensor origin. Pain there.
Lateral epicondylitis, tennis elbow.
Perfect. And the innervation rule here is even easier.
Yeah.
Everything is radial nerve.
Everything, no exception.
No exceptions. All posterior compartment muscles, radial nerve supply. Easy peasy.
I like easy, so these muscles mainly extend the wrist and fingers.
Yep. Superficial layer has things like extensor digitorum for the fingers, extensor carpi ulnaris for wrist extension adduction, extensor carpi radialis longus, and brevis for wrist extension abduction.
And the deeper layer,
has the supinator muscle, does what the name says,
Hmm?
and then the thumb muscles, extensor pollicis longus and brevis for extension, abductor pollicis longus for abduction.
Okay, extensors, lateral epicondyle, or
Yeah.
radial nerve. Simple. But wait, wasn't there a rule breaker muscle you mentioned?
Ah, yes, the brachioradialis. It's a fun one. We have a little acronym. The BRA muscle.
BRA. Okay.
B is for beer-raising muscle. It flexes the elbow best when your forearm is neutral, halfway between pronation and supination, like holding a beer mug.
Uh-huh. Okay, beer raising.
R is for rules breaker. It's an elbow flexor, functionally, but it's in the posterior compartment territory and gets radial nerve innervation. Breaks the flexor median ulnar rule.
Ah, tricky.
And A is for touches way down low on the radius. Helps flex the elbow and bring the forearm to that mid position. It also forms the lateral border of the cubital fossa.
The cubital fossa, that's the depression in front of the elbow.
Exactly. And tapping the brachioradialis tendon there tests the C5-C6 reflex. Plus, the radial nerve itself runs right behind it there, so it's a handy landmark for the nerve, too.
BRA, beer raising, rules breaker, attaches low. I won't forget that one.
Mhm.
Okay, let's revisit that anatomical snuff box. Extend your thumb back, that triangle depression.
Yep. And feel around in there, gently. You can feel the radial artery pulse.
Okay, yeah.
You can feel the radial styloid process, the scaphoid bone.
Ah, the one we worry about fracturing.
That's it. Also, the trapezium carpal bone and the base of your thumb metacarpal is crowded.
And tenderness there means.
Think scaphoid fracture until proven otherwise. Also running over the top superficially is the cephalic vein.
The Houseman's vein for IVs.
Sometimes called that, yeah. Common site for cannulation, but the superficial branch of the radial nerve is nearby too, so you need to be careful.
Good point. Okay, moving into the palm. The palmar aponeurosis, what's that about?
It's this really tough sheet of fibrous tissue in your central palm. It anchors the skin down, stops it sliding around when you grip things. Very important functionally.
And the fibrous digital sheaths around the fingers.
Those are like pulleys or tunnels for the long flexor tendons. They hold the tendons close to the bone when you bend your fingers.
Preventing bowstringing.
Exactly. Without them, the tendons would pull away from the bone and you'd lose strength and fine control. Now, here's a huge clinical point.
Okay.
The sheaths around the thumb tendon and the little finger tendon are often continuous with the main synovial sheath that runs through the carpal tunnel up into the forearm.
Continuous, like one long tunnel.
Pretty much. So an infection starting in your little finger,
Can track all the way up through the carpal tunnel into the forearm. Whoa.
it can spread rapidly along that sheath. That's why seemingly small infections in the thumb or little finger can become serious forearm infections very quickly. These sheaths can also get inflamed tenosynovitis or develop ganglions.
That explains a lot about hand infections. Okay, intrinsic hand muscles, the fine-tuners.
Right. These are the muscles located entirely within the hand. You've got the thenar eminence.
The fleshy mound at the base of the thumb.
Yep. Muscles for flexing, abducting, and opposing the thumb. Flexor pollicis brevis, abductor pollicis brevis, opponens pollicis.
And the hypothenar eminence on the little finger side.
Same idea, but for the little finger. Flexor, abductor, and opponens digiti minimi.
Okay. Then there are the lumbricals. Those sound interesting.
They are unique. They start on the deep flexor tendons, FTP, and insert onto the extensor expansions on the back of the fingers.
Weird attachment. What do?
They flex the MCP joints, the main knuckles, while extending the finger joints, the PIPs and DIPs, like making a tabletop shape with your fingers.
Ah, okay. And their innervation.
It's split like FDP. The lateral two lumbricals, digits 2 and 3, get the median nerve. The medial two, digits 4 and 5, get the ulnar nerve.
Median and ulnar again. Got it. And the interossae. Between the bones.
Yep. Between the metacarpals, easy mnemonic here, PAD and DAB.
PAD and DAB.
Palmar interossae adducts the fingers, bring them together. Dorsal interossae adduct the fingers, spread them apart. PAD, DAB.
Nice. And their innervation.
All ulnar nerve, all of them.
Okay, so that brings us to another golden rule. For the intrinsic hand muscles.
You bet. Everything in the intrinsic hand is supplied by the ulnar nerve.
Everything.
Except the thenar muscles and the lateral two lumbricals. Those exceptions get the median nerve.
So thenar muscles plus lateral two lumbricals equals median. Everything else ulnar.
Exactly. And pretty much all intrinsic hand muscles get their root supply from C8 and T1 spinal nerves.
Okay, and there's a clinical test related to this. Frument sign.
Yes. Tests the adductor pollicis muscle, which is ulnar nerve supplied. If the nerve is out, the patient can't adduct their thumb properly when pinching paper. They compensate by strongly flexing the thumb's end joint using flexor pollicis longus.
which is median nerve supplied.
Right. So that hyperflexion tells you the ulnar nerve, specifically adductor pollicis, isn't working. It's a neat trick.
Very clever. Okay, let's quickly trace the nerves themselves. Median, ulnar, radial.
Okay. Median nerve comes down the arm, usually medial to the brachial artery, then passes near the biceps tendon in the cubital fossa, dives between the heads of pronator teres, and runs down the forearm, ending up passing through the carpal tunnel at the wrist, often just deep or slightly radial to palmaris longus tendon.
Got it, ulnar nerve.
Ulnar nerve runs down the arm, famously passes behind the medial epicondyle in the cubital tunnel, that's your funny bone spot. Then it dips under flexor carpi ulnaris, runs down the ulnar side of the forearm, and enters the hand superficial to the flexor retinaculum, lateral to the pisiform bone in Guyon's canal.
So it doesn't go through the carpal tunnel.
Correct. Crucial difference, radial nerve.
Radial nerve wraps around the humerus, then comes anteriorly near the elbow, lateral to the biceps tendon, then it divides. The deep branch, posterior interosseous nerve, dives back near the radial neck to supply the extensors. The superficial branch stays more anterior for sensation.
Okay, so quick recap on motor. Median, most anterior forearm, thenar, lateral lumbricals, ulnar FCU, medial FDP, all other intrinsics. Radial imparis, all posterior forearm extensors.
Perfect summary.
Right.
And sensory. Palmar hand is roughly 3.5 fingers median, thumb side, 1.5 fingers ulnar, pinky side. Dorsal hand is more mixed but has significant radial contribution.
Fantastic overview. Now let's connect this to what we see clinically when things go wrong. Lower motor neuron damage. Yeah, if you damage the nerve supplying a muscle, you get predictable signs. Weakness, maybe paralysis, muscle wasting over time, atrophy, and the resting position of the hand or fingers might change because of the muscle imbalance.
Like Dupuytren's contracture.
Well, that's slightly different. It's a thickening of the palmar aponeurosis itself, causing the fingers, usually medial ones, to curl in passively. But nerve injuries cause active problems.
Okay. What about scanosing tendinosynovitis?
That's inflammation of the tendon sheath, causing pain and that trigger finger catching. Not directly nerve-related, usually.
Right. But the nerve signs. Ulnar claw hand.
Classic ulnar nerve lesion sign, seen at rest. The MCP joints of the fourth and fifth fingers are hyperextended, and the IP joints are flexed because the ulnar innervated lumbricals and interossea are knocked out.
And the benediction sign.
That's different. That's what you see when someone with a median nerve lesion tries to make a fist. They can't flex their index and middle fingers properly, so it looks like they're giving a blessing. It's an action sign, not a resting sign.
Okay, claw is ulnar at rest. Benediction is median on action. And thenar wasting.
That visual flattening of the thumb muscle mound. Classic sign of chronic median nerve damage, like in long-standing carpal tunnel syndrome.
Makes sense. Okay, before we hit carpal tunnel, let's close the loop on that earlier question. The interosseous membrane, what type of joint is it?
Ah, yes. It's classified as a fibrous joint, and more specifically, a syndesmosis.
Syndesmosis, like between the tibia and fibula down low.
Exactly like that. Strong fibrous connection holding bones together, allowing only very slight movement, perfect for that force transmission and stability, while still permitting pronation supination.
Got it. Okay, quick look at blood supply.
Sure. It starts way up with the axillary artery becoming the brachial. The brachial gives off the profunda brachia deep in the arm, then splits usually around the elbow into the radial and ulnar arteries.
The main forearm players.
Yep. They run down either side, give off interosseous branches, and then continue into the hand where they connect, forming two arches, the superficial and deep palmar arches.
Anastomosis. So backup supply.
Exactly. Robust supply to the hand. Clinically, you feel the radial pulse lateral to the FCR tendon at the wrist where you do ABGs. The ulnar artery is more medial, often under or just lateral to the FCU tendon.
And they branch out to the fingers.
Yep, digital arteries run alongside the digital nerves.
Perfect. Which brings us finally to carpal tunnel syndrome. Super common.
Extremely common. And it's all about anatomy. It's compression of the median nerve, specifically where it passes through the carpal tunnel.
So the symptoms match the median nerve distribution.
Precisely. Numbness, tingling, pain, often worse at night in the lateral 3.5 fingers, thumb, index, middle, and the radial half of the ring finger. And as we said, if it's chronic or severe, you'll see that thenar wasting.
And the key distinction again.
The median nerve goes through the tunnel, the ulnar nerve goes superficial to it in Guyon's canal, so symptoms in the little finger. That's not carpal tunnel syndrome. Think ulnar nerve instead.
That anatomical separation is absolutely key clinically. Wow. Okay, let's try and repack all of that.
Good idea. It was a lot.
We covered the bones, radius and ulna, the ring concept for injuries, the carpal bones with that mnemonic, straight line thumb to pinky, here comes the thumb.
And the crucial scaphoid blood supply.
Right, distal to proximal, then the fractures called as dinner fork, Smith's garden spade, the kid's fractures, then muscles.
Anterior flexors, common origin, medial epicondyle, mostly median nerve, except FCU, medial FDP ulnar. Posterior extensors, common origin, lateral epicondyle, all radial nerve.
And our rule breaker, the BRA muscle, brachioradialis.
Don't forget the BRA.
Then the snuff box landmarks, the sheaths and infection pathways, the intrinsic hand muscles, PADAB, the ulnar rule with median exceptions for thinner lateral lumbricals.
Tracing the nerves, the blood supply arches.
And finally tying it into clinical pictures like claw hand, benediction sign, and carpal tunnel syndrome, understanding why the median nerve gets compressed there.
You've got it. That anatomical knowledge isn't just trivia, it underpins everything. Recognizing fracture patterns, predicting nerve deficits, understanding why infections spread the way they do.
It gives you that clinical compass.
Exactly. It moves you from just knowing what is there to understanding why things happen clinically. It's the foundation for diagnosis and treatment in this incredibly important area.
Well, thank you for joining us on this very deep dive into the forearm, wrist, and hand. We really hope this gives you, our listener, that clear, memorable, and really actionable framework.
Absolutely. And maybe a final thought to leave you with. As you keep studying, think about how perfectly, or sometimes imperfectly, these structures are designed. That scaphoid blood supply making it vulnerable, the intricate action of the lumbricals allowing fine movement. It's all shaped by evolution. What other engineering marvels or maybe design flaws can you spot in the body that lead to such specific clinical problems when they're disrupted? Keep asking why.